afternoon. My name is Jesper Hastrup Svendsen. I'm a consultant and professor at the Copenhagen University Hospital Rigshospitalet in Copenhagen, Denmark. And I'm here to present the results from the LOOP study. We all know that atrial fibrillation is associated with an increased risk of stroke and also increased risk of death. We also know that a lot of atrial fibrillation is asymptomatic and therefore unrecognized and left untreated. We know that a high proportion of stroke patients have atrial fibrillation if they are continuously long-term monitored. And we have a very effective treatment with oral anticoagulation to reduce the risk of stroke in patients with atrial fibrillation. And with the LOOP study, we aimed to find out whether continuous monitoring for atrial fibrillation and initiation of oral anticoagulation, if atrial fibrillation was detected, could reduce the risk of stroke and systemic arterial embolism. The LOOP study was a clinical randomized trial. It was an investigator-initiated trial, and the participants were recruited from Danish registries. The inclusion criteria were age above 70 years and at least one of the following diseases which confer an increased risk of stroke. And the 4 diseases were hypertension, diabetes, previous stroke, or heart failure. The exclusion criteria were known history of atrial fibrillation or ongoing atrial fibrillation, ongoing oral anticoagulation, or contraindication for oral anticoagulation, or an implanted device which could record and find atrial fibrillation, such as a pacemaker. The primary outcome was time to stroke or systemic arterial embolism, and the trial was event-driven and required 279 patients with a primary event. We randomized a total of 6,004 individuals in a 1:3 ratio to either ILR monitoring using a Medtronic Reveal link with continuous remote monitoring, or to be randomized to the control group, which receives standard care. 1,501 participants were randomized to the ILR group, and 4,503 participants were randomized to the control group. And we had complete known outcome status from all participants. The participants were in 53% of cases males. They had an average age of 74 years. Their inclusion diagnoses were in 91% hypertension, in 21% it was diabetes, in 4% it was heart failure, and in 17% it was previous stroke. Their median CHA2DS2-VASc score was 4. They were all having marginally, their mean systolic blood pressure was marginally elevated. They had normal kidney function. During the trial, we identified atrial fibrillation in 31% of participants in the ILR group versus 12% in the control group. And the ILR monitoring had a duration in mean of 3.3 years in the ILR group. And the difference between the two groups with respect to atrial fibrillation diagnosis was significant. Oral anticoagulation was initiated in 29% of those in the ILR group and 13% in those in the control group. And in the ILR group, those with atrial fibrillation had oral anticoagulation in 91% of patients, and in the control group, 86% of the patients with atrial fibrillation received oral anticoagulation. And the difference between the two groups with respect to initiation of oral anticoagulation was statistically significant. And with respect to the primary outcome, we had a primary outcome in 318 participants. 315 had a stroke, and 3 had a systemic arterial embolism. And with respect to the cumulative incidence of stroke or systemic arterial embolism over time, we had a hazard ratio of 0.80, which was not statistically significant, with a p-value of 0.11. With respect to the secondary outcomes, combined outcome ischemic stroke, systemic arterial embolism, or transient ischemic attack, there were no difference between the two groups. And also with respect to the secondary outcome with a combination of stroke, systemic arterial embolism, or cardiovascular death, and also with a secondary outcome of death from any cause, there were no difference between the two groups. Major bleeding occurred in a total of 221 participants, with no difference between the two groups. Hemorrhagic stroke occurred in 45 participants, 0.8% in both groups, which was not significant. With respect to subgroup analysis of those with a primary outcome, there were no difference between the two randomization groups, except for the analysis of baseline systolic blood pressure. If we divided the group into 3 groups, those with the highest blood pressure tertile, which means a blood pressure above 157 millimeters of mercury, there was a significant benefit with respect to monitoring with an ILR in those with the highest tertile systolic blood pressure. When we performed a sensitivity analysis, which was pre-specified, we could see that if we had a sensitivity analysis only including participants receiving their assigned intervention for at least 3 years, then we had a total of 307 primary events, and there was a significant difference between the two groups, with a benefit in those who received the ILR monitoring. So in conclusion, in individuals at high risk of stroke, ILR screening resulted in a 3 times increase of AF detection and oral anticoagulation initiation, but no significant reduction in stroke or systemic arterial embolism. Although AF was diagnosed in more than 30% of participants in the ILR group, and 91% of these initiated oral anticoagulation, the risk reduction by intention to treat analysis was only 20% and non-significant. If we assume that the 20% reduction in risk is a true estimate, then the number needed to screen to avoid 1 stroke or systemic arterial embolism would be 62 individuals. We found no effect on mortality. We had rates of bleeding that were modest, despite our low threshold for anticoagulation, which was a duration of atrial fibrillation of only 6 minutes. Thank you.